So today's our topic would be National Health Mission and National Health programs, which are covered under the National Health Mission. So, National Health Mission was launched in 2005 under National Rural Health Mission, and which later, with the launch of National Urban Health Mission in 2013, became National Health Mission, where rural and urban were the submissions of this mission. So, the key objectives of National Health Mission is to support the states and UTs of the country towards provision of universal access to equitable, affordable, and quality healthcare services, which are not just universal but also accountable and responsive to the needs of citizen, and which also showcase an effective intersectoral convergence and collaboration and addressing all social determinants of health. So it is a whole package of not just health but also social determinants and other factors which are directly or indirectly influencing or affecting health. So, if we talk about the key objectives, the three key objectives as defined by our National Health Mission framework are first to provide technical as well as to provide financial supports to state so that their health system strengthening can be prioritized. So under the National Health Mission, while several technical aspects are covered, we also there's a provision of giving a financial allocations to states to support their health system strengthening. The second objective is to bring more focus on high priority states, or we can say high focus states, and also in rural population, particularly marginalized and vulnerable population, including the tribal subgroups. The third is architectural correction through integration of different vertical programs which were otherwise running in silos to have an integrative approach towards these programs, and also to focus more on decentralization and community engagement or communitization as the policy or as the base of the entire National Health Mission. While National Health Mission, which was earlier National Rural Health Mission, and then with the launch of Urban became the entire health mission for rural and urban areas, the objectives or goals are in alignment with our National Health Policy, which is the latest version which came in 2017, and also the Sustainable Development Goals, which we call SDGs. So, when health system strengthening is being provided under NHM, there is a pool for financial allocation and support to states, which is broadly divided into Ayushman Bharat Health and Wellness Center, which is comprehensive primary health care, free essential medicines, free essential diagnostics. For improving access to care, we have National Ambulance Service, also known as NAS, and mobile medical units. Then to ensure the quality services, we have quality assurance, which is now also known as quality and patient safety. We have untied funds, and we have human resource for health. And in addition to have all these together, we have an infrastructure maintenance pools to ensure that we have enough infrastructure to complement and to strengthen all these components of health system strengthening. If we talk about the different pool, these are the health systems. As we are aware, we have 6 building blocks of health system strengthening. So these are basically reflecting the blocks of health system strengthening, while we also have some programmatic components under this pool. So, for example, for RM and CHA, we have RCH FlexiPool, which focuses on reproductive, maternal, newborn, child, adolescent health and nutrition, which we call RM and CAH plus N, where N is the nutrition component, our new focus area. Then we have intensified pulse polio program immunization and our routine immunization, which is now being implemented through Mission Indradhanush as well. We have Rashtriya Bal Swasthya Karyakram, and then we have Rashtriya Kishore Swasthya Karyakram focusing on adolescents. Like this is focusing mainly on reproductive and child health. We have Communicable Disease Pool, which focuses on TB elimination program, vector-borne disease control program, leprosy, integrated disease surveillance program, which we call IDSP, and also viral hepatitis control program. So TB and leprosy are also one of the targets of our country right now, where our country is moving towards TB elimination by 2025. So these were reproductive child and communicable disease, while now the government focus has also shifted to more on NCD's program pool. As we all know that our country is going through an epidemiological transition where our disease burden has shifted from communicable disease and RM and CHA related components to more non-communicable disease. So we already had these pools defined under NHM or NRHM earlier, but now they are further strengthened, and this pool encompasses of prevention and control of cancer, diabetes, cardiovascular disease and stroke, control of blindness, deafness, mental health program, health program, program for prevention and control of fluorosis, tobacco control, elderly care, palliative care, and the recently launched program on dialysis, which is Pradhan Mantri National Dialysis Program. So this is overall the pools which are under NHM and through which NHM is providing support to different states and UTs. So, as the first component, which I said was Ayushman Bharat. So, Ayushman Bharat is basically a bigger platform where, with saturation approach, the country is working towards having four pillars to work together towards achieving the goals of universal health coverage. So, the Ayushman Bharat component was launched in 2018, where the first two components were Ayushman Bharat Health and Wellness Center, and second was Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which we call PMJ. So, these both of these initiatives were designed to complement each other in such a way where the Health and Wellness Center, or we say comprehensive primary health care program, was focusing on primary care, where it was all about strengthening our primary healthcare facilities, which are our sub-health centers and primary health centers in both rural and urban areas, so that we can not only deliver them an expanded range of services beyond reproductive child health and communicable disease. So before the launch of health and wellness centers, the sub centers, which are the main core unit of our health systems, which are the first port of call for rural areas situated into the village areas, catering to a population of maybe 5,000 or 6,000. So these sub-centers and PHCs were then strengthened to ensure that we are providing services beyond reproductive and child health to also include services pertaining to non-communicable disease, mental health, hypertension, diabetes, oral health, ENT care, emergency care, and elderly and palliative care, so that we are able to deliver services more closer to the community and also free of cost. So while Health and Wellness Center was focusing on primary care, the Pradhan Mantri Jan Arogya Yojana was the largest health insurance scheme which is fully financed by government, focusing on tertiary and secondary care. So basically, as we know, we have a three-tier system where we have primary, secondary, and tertiary level of care. So the primary was being taken care by Health and Wellness Center, while the secondary and tertiary was being taken care by PMJ. So it was supporting hospitalizations for across both public and private impaneled healthcare facilities. So empanelment was one of the key over here. So while this was what was launched in 2018, post on we can't say post first wave of COVID, even during the COVID, our government realized that we also need to go ahead in providing a more strengthened infrastructure to our country. So in 2021 there were two additional programs, the remaining two pillars which were launched. The first was Pradhan Mantri Health Infrastructure Mission, which is PM Abhim. So PM Abhim is largest pan-India infrastructure mission, which has a huge grant just to support infrastructures across all levels of care, to ensure that we are not limited to any primary care or secondary, but to reach out to community, from community-based interventions to primary health care. It's also supporting establishment of health and wellness centers in both rural and urban areas, establishment of polyclinics to provide the specialized care in the slum areas, in urban areas, to have block public health units so that we can have our own integrated surveillance mechanism, and public health unit at the level of blocks, which will be further strengthened by integrated public health labs. So integrated public health labs will be at the level of districts, which will be the hub for these BPHUs, block public health units, and they will be supporting both the laboratory functions as well as the surveillance. And so it will be a strong public health unit at the district level. Then, not only that, the program supports critical care blocks. So, what happened during COVID? We realized that because of the stigma, taboo, and people were so scared that this infection can spread, so even non COVID essential services were getting hampered. So, people try to avoid visiting any hospitals, thinking if they are COVID patient, then there is more chance that even I gets COVID or I get that infection. Thinking that in mind, the PM Abhim program also focusing on like establishment of critical care blocks. So we have a separate blocks for such future public health emergencies. So these critical care blocks are being established at the level of district, and not only at the district but also in 12 main central institutions across the country. So that is establishing the critical care blocks. In addition to that, some more support for human resources at this level, strengthening capacities or infrastructure of those institutions. Then ensuring the more virological labs, ensuring more strengthened NCDCs in the country, and then port of entries was one main criteria, that all the new port of entries, whether it is by air, by water, by road, they will have an established surveillance mechanism for such public health emergencies. Then it also focuses on IHIP, which is Integrated Health Information Platform, so that we have a more an established mechanism for dissemination of information, for surveillance, for research, so that such kind of forecast can be done within our country, and we can help and we can respond timely to such public health emergencies. And in addition, research is an important component which is also included in the PMAB. Then the other program was PM Ayushman Bharat Digital Mission, which is ABDM. So National Digital Health Blueprint was launched earlier to check on or to have a blueprint on how this digital mission would be rolled out. So now Ayushman Bharat Digital Health Mission is already launched. We have an Aadhaar ID system which has been created for all individuals to have their own personal unique ID. So the objective is to ensure access and equity, and also to have a continuum of care with citizens who will be owner of their data. It's not that data no more belong to any other agency or government. No, we will have more access being an owner of our own data, leveraging more IT and associated technology. So the whole idea, the common component across all these four pillars of Ayushman Bharat is a citizen-centric approach. Whether it is Health and Wellness Center, whether it is Ayushman Bharat card, whether it is PM Abhim, or whether it is Ayushman Bharat Digital Mission, the common chord connecting all is the citizen-centric approach. So that is the base of all our interventions under NHM. So this is explaining the universal health coverage in one slide. That what we mean by universal health coverage, talking in relation to the programs launched under Ayushman Bharat. So as we see the base of the triangle, we see a huge chunk which is covered by existing services on RM and CHA. So this was the met need where before 2018, our primary healthcare facilities were providing support for RM and CHA, and some to some extent for communicable disease also. So we had the NSSO data reported that there was highly like underutilization of healthcare facilities at primary level. It was so low, even low to the 11% or 7% below the level of CHCs for rural and urban areas respectively for any other services other than mother and child care. So people were visiting these facilities limited to ANCs or MCH or RCH related functions, and to some extent for communicable diseases. So we were not able to utilize the resources at that level, which were established as an objective that the government thought of providing the services more closer to the community. And there were a lot of unmet need in terms of NCDs and other chronic conditions. So there was a huge gap. If you see the white part on the base of the triangle, that was the huge gap of unmet need. To close this gap, we had the comprehensive primary health care through health and wellness centers, which have progressively 12 expanded packages, which is communicable disease. First six packages are the existing services pertaining to reproductive and child health, family planning, communicable disease, acute illness. And the remaining six were spanning non-communicable disease, eye and ear, and oral health, mental health, elderly and palliative, and emergency care. So the program focuses on preventive, promotive, curative, rehabilitative, and palliative care as an integrated approach. Then we see the second half of the triangle, which is the blue part. It talks about the secondary services. So then you see a line in the triangle, green line, which says referral and gatekeeping. What do we mean by referral and gatekeeping? So in the absence of having an HR at HWC level, and in the absence of having all services at that level, the community was directly reaching out to secondary level care. So what was happening? There was overcrowding at secondary level. There were more crowd over there, which was also hampering the quality of services, and there was no gatekeeping, or we can say care coordination. By strengthening the primary health facilities, we ensured that people who need a basic primary management can be handled at that level, so that they do not have to go to the higher level, which is both difficult for them also to travel to larger distances and also causing crowding at that level. So that's the link where the primary healthcare also supported care coordination component. Then we have the tertiary, which is the orange part, which is the topmost part, which includes the medical colleges. Secondary includes our CHC, subdivision hospitals and district hospitals. So they were both being also covered by PMJ in panel, public and private healthcare facilities. And the another component of universal health coverage is we see the triangle how from the base people are reaching towards the top if needed to tertiary care. But the main mantra over here was continuum of care. That is having once the person reaches the tertiary care, then let the person reach back to the community and go back for a follow up there to ensure there is a treatment adherence, to ensure there is no complications, and to ensure that the person got whatever she or he wanted at that level. So these are the service packages. I will not go much in detail as I have already spoken about them. Just to go on quick, the first six services are more related to RMN, CHA, and CD, communicable disease, and acute simple illness. The seventh is non-communicable disease, which is gray over here because this was the first package to be released under HWC before HWC were formally launched in April 2018 in Chhattisgarh. The rest of the five packages were also launched later on in an incremental manner. So now talking about NHM through levels of care. So as I said, the first approach of NHM is to be patient centric. It doesn't think from the perspective of a service provider, but more from the perspective of the community. We have a community level interventions. We have ASHAs. We have an ASHA in rural area for 1,000 population and in urban area for 2,000 to 2,500 population. We have her support structure, which is an ASHA supervisor in urban areas or an AM or a block trainer, while a ASHA facilitator, which is in the rural areas. We have VHSNC, which is Village Health Sanitation and Nutrition Committee, which is a community-based forum and rural areas. And the counterpart in urban area is Mahila Arogya Samitis, which is MAS. So these both are community-based platforms, which are generally taking care of all community-based engagements to have a more approach of community as a stakeholder in health system and not just as one of the taker of those services. Then while we had community based platforms, we have a facility, there was a linking community and facilities. A new committee has been formed, which is Jan Arogya Samiti, that is JAS. Earlier we used to have Rogi Kalyan Samiti, but why Rogi? Why not let keep focus on having them Arogya? So Jan Arogya Samitis are the newest reform under ABHWC, which is Ayushman Bharat Health and Wellness Center. So these facility-based committees are more actively engaged with community and showcase their participation all throughout their activities. It also includes community-based monitoring. In addition to this, NHM also encourages engagement with civil society organizations and NGOs wherever required to support the implementation across the domain areas of health system strengthening. We have strengthening of health facilities. So infrastructure support is something which is supported by NHM. So we already have defined infrastructure standards, which is called Indian Public Health Standards. The last IPHS was launched in 2012 and now it has been launched in 2022. So these infrastructure norms are same throughout the country and a guideline has been prepared for these IPHS standards, which not only set standards for infrastructure, but also there are mechanisms to ensure that quality accreditation is done for all public healthcare facilities. So we have a National Quality Assurance Program, which is NQAS, which ensures or which work towards ensuring the quality accreditation of our public healthcare facilities. In addition to it, now when we know infrastructure has been talking about, the standards have been talking about, the availability of human resources, one core area for strengthening the health systems. So while we already have a defined structure of HR availability across all our public health facilities, which is again defined as per IPHS, when CPHC came into picture and it was launched, it was decided to have an additional infrastructure and human resource for comprehensive primary health care. in addition to what has been defined, where health and wellness centers were given additional fund to support their infrastructure because the gamut of the activities was expanding. We also got an additional HR, a new cadre of worker, which was launched at the level of sub-center health and wellness centers. Earlier, the sub-centers had a composition of ANMs and ASHAs at that level, and most of the time ANMs were also busy in outreach, thus leaving several times the sub-center would be logged. So that was also one main reason for underutilization because of the journal notion that the sub-center is mostly logged. With CPHC coming into picture, a new cadre of non-physician health worker was introduced, which was MLHP, or which was CHO, community health officers. These community health officers were working as a team lead and supporting the team at the level of ABHWC. Then, not just with the availability of HR, our second concern was like we cannot just keep on increasing HR to ensure the availability of services. So, how to build their capacity, how to do their skill building. So, ensuring task sharing and task shifting was another thing which was thought of while implementing this program, and multi skilling became another approach. So, while we were establishing HR, building their capacities, one main reason of attrition is lack of opportunities in public health systems. So, another way out was how to plan for a career progression mechanism for this set of HR, which is supporting all the public health facilities under NHM. Then we have access to care. So for access to care, we have facilities are, although we are now reaching more closer to the community to have health and wellness center at the level of villages. But for improving access to care or for outreach services where we cannot reach, referral transport has been ensured, and we also have ambulance services working across all states. Then the strengthening of primary and secondary level care, I already explained. The primary is being done through Health and Wellness Center. For secondary level care, now CHCs are being strengthened, more services are being provided to complement our comprehensive primary health care. It should not happen that we have X number of services at primary health care, and when the patient is being referred to higher level, we don't have those services being reflected over there. So secondary level of care is also being strengthened to complement and to reflect on the primary healthcare interventions. Free medicines and diagnostics, we see that was one main reason of out-of-pocket expenditure, where the NSSO report more than 70% of out-of-pocket expenditure for medicines. So free medicines and diagnostics program was launched in 2015, which has now got revised updated list to again complement the efforts of strengthening primary health care and also strengthening of secondary level of care. Now, when we talk about medicines and diagnostics, supply chain is one another component to ensure how we channelize and streamline the supply chain management of these for both medicines and diagnostics, how to ensure there are no stockouts, how to do indenting. So IT-based supply chain management was also introduced in our system. And to maintain the quality of diagnostic labs, we also have accreditation of diagnostics labs, and we have options of both. So while NHM always supports building in-house capacity of states, for states which need some time to develop their in-house capacity, it also gives them an option to initially take this up on public-private partnership, but later on they say ki we have to eventually come to the in-house capacity. Prescription audits are the another thing which has been launched by government. And as I told about Ayushman Bharat Digital Mission, IT-based enabled solutions are there across all domains of health systems, whose integration is a key component under ABDM. Financing, NHM has a lot of options to support these programs. And recently, with the additional resources like 15 Finance Commission, which gave a huge grant to support health through the decentralized mechanism, that is through the local bodies in both rural and urban, and also through the largest pan-India infrastructure scheme, that is PM Abhin. Now finances are no more an issue. So we have finances, it's just how we go ahead with that. NHM also has an institutional mechanism. We need the committees or some the groups across different levels who not only guide the program, govern the program, but also give directions to our policy. So if you talk about policy direction, the topmost body is the mission steering group, which not only gives directions to the entire NHM, but also look into all the proposals as presented to mission steering group after being passed through empowered program committee. Then we have National Program Management Unit, NPMU, which looks after all the programs at NHM. Then we have technical support to both center and state, which is NHSRC, National Health System Resource Center, which is supporting all the component of health system strengthening in states as a technical agency to Ministry of Health and Family Welfare. For the training component, we have National Institute of Health and Family Welfare, and we also have network of public health institutions for institutional capacity development. We have NCDCs, we have AIMS, we have PGIs. So they are all institutions of national importance to Ministry of Health and Family Welfare. So just this was a brief discussion on NHM and programs. NHM and programs are so vast that it would need, I don't know, a really long time to get through each and every component of that. So I tried to be pretty short and brief so that I can at least give I can keep a note of each and every component and at least give a reference of all the important components of NHM. So if we talk about what is the take home message for us, so we observed there was a low public health expenditure on health, and there was a more cost going for the private healthcare. So how did government respond to it? We increased our public health expenditure, state and central share, and we also got this idea of flexible funding pools. Then we had the context where there was low fund absorption, and also in the public health system, the efficiency was not very good for utilization of these funds. So what happened? We developed institutional structures for more improved government and management. We had state and district level health societies. We have facility and village level committees to participate and to also ensure that fund utilization is no more a challenge, but to be taken up as an opportunity. We saw that earlier the infrastructure norms were more conforming to population, less to access, coverage and quality. So it was very leading to unsatisfactory responses within the community, that this is the norm for this number of population, this will be the facility. So this has been changed now, where now we are focusing, not norms are one thing, but not focusing much on that, but focusing that we at least are able to provide minimum package of services and quality of health services more closer to the community and free of cost. And we had fragmented vertical programs. The RCH, before the launch of NHM in 97 and 99, we used to have RCH program, RCH1, then came RCH2. We have a separate program for TB. We had a separate program for 1980s for mental health. So we had a very fragmented vertical programs. But through NHM, now we have an integrated systems. So the health system approach has kind of integrated all these programs, then running in silos. So we also had a crisis for human resources where, as I said, multitasking or health contractual appointments under NHM, walking interviews, incentives, it all helps, and also involvement of Ayush practitioner into the health systems also helped a lot. In the sub-center level, we saw a provision of second A&M came as a response so that at least we can address the HR shortfall components or issues across the state. We had a context that communities' involvement and local government involvement was not much. So addressing social and environmental determinants was a challenge. So the care seeking was strengthened. The behavior change was one of the things focused on, facilitated. Decentralized health systems were created, and district health societies were empowered to take on this role so that we can also finance our district health plans, which are more oriented at the level of district and reflecting their key challenges, their models, and their issues and concerns. So it became more district specific, more decentralized approach to present our planning and to get approval thereby. Then there was a lack of access for community-based healthcare, and also we came across the challenges of delay in care seeking. So ASHA came as a very strong pillar, came up as a cornerstone to our health systems, who provided level of care at that level, the level of community. So ASHA is one community health worker who belongs to that community, thus represents that community, and she was able to provide level at that component addressing the community-based challenges. And this was further supporting strengthening of outreach activities where VHSNC and MAS, like community-based platform, further act and complemented these activities. So that's all a brief intro of NHM and national health programs and the key interventions under it. And it's a very big topic. So if there are any queries and if there are any concerns, you can write to me or you can reach out to me. I'll try to answer each and every question. Thank you.